All right, good afternoon, everyone. I'm Hope. I have the pleasure of hosting Dr. Pratt today. So before I introduce him, I just have a few quick reminders for everyone. I think the assignment for today's seminar is not yet on Canvas, but we will have still the normal 3 questions and then name of presenter, name of presentation. So just take notes on that on a separate thing, and I'll email Dr. Nasiri and make sure that that gets uploaded to Canvas. So be on the lookout for that later this week. Don't forget to sign in. The sign-in sheet should be floating around. And then also there's snacks up here. So on your way out, feel free to grab some fruit snacks and chips and things. So, with all of that being said, we are very lucky to have Dr. Pratt here today. He's a professor and the director of the Institute for Public Health and was the founding director of the MPH program at the University of California, San Diego, Herbert Wertheim School of Public Health and Human Longevity Science. He's also the chair of the Global Observatory for Physical Activity. He spent the 2022 and 2023 academic year as a Fulbright Distinguished Scholar at Healt University in the Czech Republic, working on physical activity and public health policy development and implementation. And he engages with researchers and students across the UCSD campus and with public health professionals in San Diego, California, nationally, and globally. He's worked in more than 30 countries with a focus on building research capacity and partnerships for physical activity and public health. And his major projects have included co-leading the 2012, 2016, and 2021 Lancet series on physical activity and global health, developing the International Physical Activity Questionnaire, developing the first public health recommendation for physical activity, creating national and global research and practice courses for physical activity and public health, and directing 50 courses in 20 countries. He worked closely with the Prevention Research Centers program at CDC and helped to develop 2 of the PRC research networks of physical activity policy and global and territorial health. So really a storied career and really wonderful things to share with us today on the intersection of physical activity and transportation. So thank you so much, Dr. Pratt, for being with us.
Great. Well, yeah, thank you, Hope. That was a long introduction, which you tend to have if you stay in a career a long time. There's all kinds of random things you've gone in. So I actually am adding 3 slides here based on the conversation we had coming in. So I am, in fact, a native of this town, and I was literally because my dad did his PhD on tomatoes. We see a classic Davis picture there. I usually have this at the end of talks and I ask people where it is. Obviously I can't ask that question here, but and you can see the snapshot of my wandering career there. So you get the 3 Davis slides here. That's my great-grandfather down there. I'm glad that my grandfather on the upper right there and my dad in the middle became academics, because I'd much rather do talks like this than drag rocks around a farm field in upstate New York. Yeah, so we won't go into the rest of that. That was actually my dad's postdoc lab, and there's a guy in the middle there who won a Nobel Prize. And so I am also a graduate of this university. You can see a very long time ago, and in an era where we looked a little different than today. So yeah, I ran track and cross country at there. So that's the end of that slide, and now we'll go to the other presentation. Okay, so this is actually the talk. So I'm a public health physician who specializes in physical activity and health, with some various wanderings along the way, which obviously overlaps a lot with what people in urban planning and transport, especially active transport, do. But it's not. But it also is a field with its own jargon and own norms and stuff. So feel free to stop and ask questions anywhere along the way. We have quite a long time. I certainly won't fill it up talking, I hope not. So yeah, ask questions, raise your hand. My hearing is bad, so you may have to shout out the questions. But and so started at Davis, but now I'm in San Diego, You know that's not a Davis scene there, but you know, Davis. I actually had a friend when I was an undergrad here who came from LA, and he said, you know, people think California is Tahoe and the beaches and surf. To Davis, why do you go to Davis? Flat dirt. And I'll always remember that. So a lot of the work I'm presenting comes from time when I was at the Centers for Disease Control and Prevention, and those are with many collaborators. Public health is very much team science, and so those groups up there are a number of the people I collaborated with at CDC. And I kind of stumbled into global health work, but these groups are groups that were involved with the Lancet Physical Activity. The Lancet is probably the most cited, sort of highest impact public health journal, and we were lucky to get a series of series in the Lancet to kind of help push physical activity into the mainstream, and that's a group of collaborators there from various places around the world. Mentioned the Lancet, and this was the takeaway of that first Lancet series, and it actually we got into a bit of a fight with the editor of the Lancet because people in public health don't think of behavior like physical activity or its inverse, inactivity, as being something that could be an epidemic or a pandemic. But in fact, if you look through last dictionary of epidemiology, sort of a Bible of the field, pandemic is when you have a disease or a condition which occurs at a greater than expected level across many countries and many different populations. And physical inactivity meets that description. And I think we have a couple other slides, and it has a second issue that's going to allow the collaborators there. So a lot of people are inactive. About a third of adults around the world, varies country by country. And generally in most countries, there are more women who are inactive than men, and typically inactivity levels go up with age. Inactivity levels are also high among adolescents. Yeah, you might be doing sort of a double take. How could 31% of adults be inactive and 80% of adolescents? It's because the definitions are different for those age groups. So we expect adults to do 150 minutes, so 2.5 hours of moderate to vigorous physical activity a week. We expect children to do 1 hour a day, so 7 hours in that same week. And so that's why the discrepancy. But they're both reasonable recommendations and not that hard to reach. And so there's a lot of concern that the trend of many inactive adolescents will lead to many more inactive adults and the associated chronic diseases. And that's this one. So it turns out that physical inactivity, much like high blood pressure, smoking, obesity, if you look at the big cohort studies, which are typically used to look at long-term health impacts of health behaviors and conditions, inactivity is right there with those other conditions as an underlying cause of mortality. And why is that? You can see from here that with these major diseases, we can look at heart disease. Inactivity increases the risk of heart disease, controlling for everything else about 16%, breast cancer about 20%, diabetes 20%, breast cancer by a third, colon cancer about the same. So and all-cause mortality by almost 30%. So inactivity increases the risk for the big killers. And then not surprisingly, the total mortality due to physical inactivity is big. And Hyman Lee, very good epidemiologist, led this paper. It's about 9% of premature mortality, which works out to about 5 million deaths a year. So you can, and that's very comparable to tobacco, a little less than high blood pressure. Diabetes is a bit less than that. Not all of the diabetes is caused by physical inactivity, obviously. Inactivity causes lots of morbidity and mortality. So from a public health standpoint, we care about that. It also turns out that if you cost out the healthcare costs and in some of the analyses also the indirect costs associated with inactivity. So that would be not just things like the hospitalization costs, but the additional costs due to somebody missing work or family members having to take care of that person at home. The costs of inactivity are very substantial. And this was a global estimate, a very conservative one. But the numbers are, at least to me, are somewhat meaningless. It's really thinking about them in comparison to other important health issues. And again, physical inactivity falls into the same broad conditions as far as its economic costs. One thing that was kind of interesting. I have to go down.
Maybe it's not clicked on the. Is it clicked on the window for the presentation?
Okay. Yeah. Okay, that worked. So we were talking about the direct costs, basically the healthcare costs associated with inactivity, and you can see, maybe a little hard to see, the red are high-income countries, and the blue are low and middle income countries. So this is an interesting slide because, in part because high income countries have expensive healthcare systems, of which you guys may not deal with this on a regular basis, but you probably see it in the news. It basically costs, we spend twice the proportion of GDP as other wealthy countries on healthcare costs. So 80% of the healthcare costs associated with global physical inactivity are in high-income countries. Anybody, quick estimate, what proportion of countries are high income by World Bank categorization? It's about 10%. And then 90% are low and middle income countries. You can see the indirect costs fall substantially more on low and middle income countries. It doubles. But the disease burden is primarily in low and middle income countries. So you have to be, this is a sort of a cautionary tale with economic analyses. They can, unless you take the context into account, you could misinterpret this data, for example, to show that physical inactivity is really just a problem in high income countries. 80% of the costs are that. Well, no, almost 80% of the disease is actually in the low and middle income countries. So, okay, so these first few slides were really just to introduce why physical inactivity is a big public health issue. It causes lots of morbidity and mortality, healthcare costs, and it's an issue in all types of countries around the world. This was a conservative estimate. Some of the estimates, we were talking about this earlier, done just in the United States with a little bit better data from the National Health Interview Survey and the Medical Expenditure Panel Survey, which is, so it's a better type of analysis because it's the same people who are producing the data on health behavior and activity, and their healthcare costs are tallied up by the sub-survey, Medical Expenditure Panel Survey. And almost 10% of healthcare costs in the US based on that analysis are attributable to physical inactivity. So it's a big health and economic issue. Not surprisingly, both countries like the US and many other countries, but also the World Health Organization have developed recommendations on how much physical activity people should do. They initially did this in 2010, updated them in 2020, and will undoubtedly update them again in a few years. And the general recommendation across many different countries and WHO efforts is fairly straightforward. People should do 150 minutes of moderate to vigorous physical activity. Same for adults and older adults, as I mentioned, a little more for children. And we'll get into this a bit later, there's some interesting issues which are now being brought up. I won't go into this too much, but it's a question of, is all the current tagline for the WHO recommendation is every step counts, or you could, those of you who work on cycling could say every cycle counts. There's a push from a number of people, especially working in low and middle income countries, saying, wait a minute, there's data that suggests that some types of circumstances and occupational activity may not actually be good for health. These people have worse health outcomes, not better health outcomes. So this is a challenging area of research. A lot of this is being done in Northern Europe, but then now more and more in low and middle income countries. So there's all activity may not be the same, but the basic public health message for a long time has been this consistent one of 150 minutes of moderate vigorous activity. And I suppose that's a jargon thing. Moderate activity is walking, slow cycling. Vigorous activity is more like jogging, swimming laps, playing soccer, things like that.
So is there any indication that this is because they're doing dangerous physical activities? Like, I don't know, jumping out of airplanes or something, like extreme sports, they're doing things on bicycles that are actually going to be going off ramps in the air.
So this is a good question. So there's a couple of theories on this. One is that people are being active in adverse environments. So for example, bicycle commuting is a good example of this. If you were bicycle commuting in a highly polluted city in India or in Latin America, that's probably very different than bicycle commuting in Denmark. So you may end up with it could even be that the physical activity is positive, but there's environmental exposures which cancel it out. Second issue is that there may be occupations in which there's repetitive activity, which hypothesis is that a psychological difference between activities of choice, oh, I'm going to go for a nice walk on a fall day in Davis, versus no choice, I'm having to work hard because I need to feed my family and I'm having a complicated and active commute to get to this job, that these things are quite different and that you get stress responses in your body that are negative. So there's probably multiple things going on, and it's actually a bit of a controversy in the field because for a long time we believed long ago the idea was you had to be vigorously physically active and in something like a runner training for a 10K in order to get health benefits. And then that evolved starting in the 90s basically to, it turns out the walking is good for you. And then it's further evolved to what you guys are doing right now, sitting a lot, is bad for you. So that there's kind of a full spectrum of doing nothing to doing a lot. And as long as you move up that continuum, it's good. And now there is a reconsideration of whether that's overly simplistic.
I know that makes sense. Like if you're logging, if you're mining, if you're a farmer that's being exposed to pesticides, all those things are actually
all of these, yeah. And because typically what this literature finds, well, originally most of the literature was in high income countries and higher income people. Some of the big epidemiologic studies were Harvard and Penn alumni, nurses' health study, physicians' health, population-based, but Framingham, Massachusetts. So they were not you get at issues like what you're raising.
Okay, thank you.
Okay. All right, so exactly, just look there, yeah. So the World Health Organization has gone beyond just saying people should do 150 minutes of physical activity a week, but has developed an action plan for the types of things should happen. And I think, yeah, so let's go to the next slide. And you can see on the bottom of that previous slide that it was tied in with the Sustainable Development Goals. So the idea was that this required that changing population levels of physical activity is not merely a matter of providing education and convincing people to make a personal choice to become more active. It's a systemic issue. You have to consider environments and policies and potential synergies with other important things. And so that the WHO action plan is very much what we would think of as a modern multi-sectoral partnership-based approach, looking across all the things that influence people's behavior and ideally providing some steps to change them. So, okay, so the next slide, it's a little bit of a change, but it gets at the topic of the presentation, which is, okay, inactivity is a big problem, causes lots of health and economic consequences. We have recommendations of how much more activity people need to do to become healthier. We've considered this from not just the individual perspective, but from a broad societal perspective. So is there anything we can do about it? And as you might imagine, researchers in fields of public health and behavioral science and medicine and a few in active transport have pondered this question and have carried out studies to assess whether they can in fact get people to be more active. And within the US sort of healthcare ecosystem, there have been efforts to systematically review the evidence, both in clinical settings. So there's something called the Guide to Clinical Preventive Services, which was the predecessor of what I'm showing up here. So that was looking at evidence on things like how often at what ages and over how many years should women get mammograms? How do you screen for colon cancer? And so forth. And then made specific recommendations on these things. And then the public health people said, wait a minute, that's all well and good, but how about at the population level? What can we do for HIV, for tobacco, for infectious disease control, for physical activity? And so there were evidence-based reviews carried out by a combination of academics and government scientists to look specifically at the literature first to categorize the literature. What are the different things you can do, for example, to get people more active? And then to review that literature and make recommendations based on the quality of the data. This has been a little bit tricky because it evolved from a clinical medicine perspective where the gold standard was considered to be a randomized double-blind controlled study, which obviously you can't really do for most of the things we might be interested in getting people to be more active because you're working at a community level. But that said, the initial idea, this slide's a little bit old, it's been updated, but you'll see another slide that presents it in a slightly different way. But the idea was that there are informational approaches in the yellow, that there are behavior change strategies, and that there are policy and environment changes. And that within each of these, there are several different ways you can categorize the evidence and potentially increase activity levels. And then on the right, a number of years back, this was the classification was something is effective. That is, there's both higher quality studies and a fair number of them, so quality and quantity, that suggest that this works. So the top one, for example, it's kind of a silly one, you might think, the point of decision prompts. That actually means putting a sign by an elevator and stairwell, telling people to take the stairs for some reason and not the elevator. Well, it turns out this actually works as long as you make the stairwell accessible, the door's not locked, as you make it attractive and so forth, you can divert people from sedentary activity, riding the elevator, to a more active one going upstairs. And so, for example, based on that evidence in the building we had at CDC, we turned the stairs away from being just the emergency exit to having music, lighting, carpeting, artwork, as well as the signs by the elevator. And not surprisingly, again, within a health organization where there's a fairly significant social pressure to do things like take the stairs, that combination did get many more people using the stairs. But on a bigger scale, that kind of thing works. The behavioral scientists this is now a few decades back, kind of moved into this field. Previously, it was mostly physicians and sort of biological scientists. And, the typical physician approach would be, I'm Dr. Pratt. Right? I'm telling you, you should walk 30 minutes a day. Goodbye. and guess what? That doesn't work very well. There are many barriers. First, people may forget it. They may have to go home, take care of children, go to their job, whatever. So behavioral scientists developed somewhat more nuanced approaches. And it turns out that, in fact, these do work if you provide the right sort of supports. But on the big picture, the policies which determine what the environment looks like and which behaviors are incentivized and disincentivized, and the environment itself probably make even more of a difference. So if you live in a place like Davis with 100 miles of bike trails, good signage, low crime, low pollution, very bicycle-friendly policies at the city level. You live here or you live in Amsterdam, for example, you will find it much more easy to become physically active than if you, as city I spend some time, if you were in the middle of Sao Paulo and it's polluted, crowded, dangerous, the sidewalks aren't good and so forth. So evidence-based approaches to promoting physical activity. Wrong, there. So
which of those strategies are more or less effective for high-income countries compared to lower middle-income countries? I know you just touched upon it a little bit, but.
Yeah, so it's a good question. So we actually did, in the early 2000s, we decided to test that very question, focusing on Latin America. So we had a project with CDC, US universities, mostly WashU and St. Louis, it's a fine one, several universities in Brazil and Colombia. And we did the same sort of review that produced that previous graphic. And it turned out 2/3 of the studies which we identified didn't fit into that categorization. They were mostly open streets types programs. People here are probably quite familiar with open streets, and I'll present some data from Bogota and open streets a bit later. So they were using public spaces and providing some sort of support for using them. And those didn't show up in the US North American literature. And then the other category were actually free community-based physical activity classes, usually in poor neighborhoods, and usually using existing public space, but oftentimes having to sort of say rehabilitate that space because it was dangerous park space, and without some kind of civic intervention, people wouldn't come to it. It's probably not fair to say that there are categories of interventions that will work in all lower middle income countries versus recognizing that there's a lot of diversity there. The types of programs that seem to work better in Latin America are very community and social interaction based. Because that's, again, it's a bit of a stereotype, but it seems to play out there, is that these are these things are valued more in that culture than they are in a highly individualistic culture like here. So you get some differences like that. We'll get into this a bit. So this is another categorization. This one's done by the International Society for Physical Activity and Health. And the idea is to sort of simplify the previous evidence-based reviews and identify 8 different areas you can work in. And some of them are quite obvious. You can work in schools or in and around schools. You can work through the healthcare system. Physician advice, if it's coupled with referral to somebody who has more time than the doctor, and then eventually leads to a community referral, actually has been proven to be effective in getting people more active. It's really difficult to get healthcare systems to do that, but if they do, it gets people more active. The interesting one up here, and then other obvious like workplace, community-wide, but up in that corner is active urban design and active travel. So these things of more interest to this group. So I'll spend a little bit of time on those. The other thing that is worth considering in this, in part because, well, I'm hopefully convincing you that physical inactivity is a really big public health problem. It's important, we need to do something about it. As a field, we have not been very good at convincing high-level health and other policymakers that in fact this is true. And so in some places, many big cities in Northern Europe would fit that category. In places like Davis, you have policies and environments which are highly supportive for getting people to be more active. And no surprise, people there are more active. But in most parts of the world, it's an uphill struggle to be more physically active. And the case hasn't been made strongly enough or well enough, perhaps, to do it. And so part of the idea in sort of thinking about physical activity and how to promote it is maybe we would do better with this if we tied ourselves to another important issue, like, for example, climate change. And again, probably people in this room are more familiar than I am with the issues around if we get people out of their cars into transit systems where they walk to and from on either end of the trips or on bicycles, and we provide infrastructure and policy supporting it, we'll reduce carbon emissions, we'll make the world a better, people will be healthier and the world will too. So that's kind of the idea. The other issue that has come up more recently is it turns out that physical activity may be important for increasing population resilience to infectious disease pandemics. And this was, not surprisingly, there was a lot of health research done on COVID, and it was done very fast because of the urgency of the situation. And it turns out that people who were regularly physically active were less likely to contract COVID, less likely to be hospitalized. If they were hospitalized, less likely to end up in the ICU. If they were in the ICU, less likely to end up on respiratory support and less likely to die. So it turns out that controlling for as many things as could be controlled for, and there are always issues in this where you may end up having a healthier population, which because of that is more active. So you have to worry about some confounding there. But it appears that regular physical activity is a relatively cheap way of making populations more resistant to the effects of infectious disease pandemics, COVID. So, okay, so systems approach, all of these things are interacting, and the idea is how do we get the people to be more active? So I kind of introduced this issue before, and so that as a public health physician who does research but is also interested in actually seeing things happen in the real world, kind of pose this question. So, and it's an interesting one. It's a general issue in all research areas, obviously. How do you get research into practice, and how long does it take, and does it do this effectively? Some of the implementation science research suggests that it typically takes about 17 years to go from proving something in research to getting it into widespread public use, that's really depressing. On the other hand, what we saw was in COVID, even though the responses were imperfect and in some countries, like ours, quite flawed, things happened fast. Vaccines were developed, public policy was changed. Whether all the policies were right or not, they were changed and implemented very quickly. So it is actually possible to go from research into policy and practice much more quickly than that 17 years, but it may require sort of an emergency situation. I'll kind of touch on each of these. So some of this, well, we'll get to them. So you can see you can just not implement something that you know works. You don't have enough money for it or people trained and so forth. It can turn out that getting from the research to practice, like the example I provided of physician counseling, is quite difficult. You can, in a research setting, you can set up the ideal scenario of 30 seconds of a physician providing advice, passing on to somebody else in the healthcare system who provides more detailed information, follow-up information, some phone calls, online support, and then a referral to a community setting where there's both a place to be active and somebody to support it. So you can do that in a research setting, but it turns out it's not very easy in real world healthcare systems. So, and then non-scalable research models, good examples of this are things that are proven to be quite effective. If you use good behavior change strategies tailored to where a person is and have a significant follow-up, you actually can get them to become more physically active. But it takes a whole lot of work. And it's sort of akin to having a personal coach and a personal trainer, which is great if you can afford such a thing. But at a population level, we're not able to afford this. So, and then finally, and thank you for the question on middle-income countries, stuff that works in a place like Davis may not work so well in many parts of the world. And without doing the research in those places, it's unlikely that we'll figure out what actually works in those contexts. So. Yeah, so brief pause for comments or questions, and then we'll do some high speed. This is a sort of speed dating by countries in physical activity. We'll look at four examples of countries that kind of answered these questions and seem to do it right.
So, you know, from the transportation standpoint, you mentioned sort of moving people into active modes is really important. And in our design guidance for last mile connectivity, we see a lot more of that. But we're also now seeing, thanks to our colleagues in Silicon Valley and elsewhere, e-scooters and electric assisted bikes. And just, you know, in your mind, does that solve a problem, or is it just sort of pushing the problem down with less activity? You know, where do you fall?
I'd say it's a mix. It's prominent. Piloting an e-scooter a few miles, you are standing up, you are having to use muscles to hold yourself in place. It's probably way better than sitting in a car, but it's certainly not as good as riding a bicycle. And yeah, so it's worrisome. In a talk like this a few years ago, I would have, and you'll actually see, I would have pushed the idea of more evaluation of bike share programs, but it seems like e-scooter and e-bike programs are largely eclipsing bike share programs. So it's like, at one point it looked like bike share programs could be a large scale way to get more people out. You know, you subset, and clearly there were examples in China of very large scale bike share that was being used. And so, yeah, so it's a two-edged sword there. Yeah. So, okay. So in this paper, first we took a look at something called a socio-ecologic model. Are people familiar with that? This is public health jargon, but the idea is that there are multiple levels that influence the choices that people make for any health behavior. And they basically start at the individual level, interpersonal, then they go into interactions with other people like family support, and into a community level, and finally at the higher level policy and environment. And so what we did is there were 20 or so interventions that were identified as effective, slightly updated. And so we plotted those across the socio-ecologic model. And so you can see, the thing that's important here for promoting physical activity is it's not a simple behavior. It's complicated, and there are influences on whether people are active or not at all of these levels, and therefore there are, not surprisingly, strategies to change that behavior at all of these levels. So from a societal standpoint, you know, if you're the public health commissioner and your mayor, governor, whoever the higher up is, has identified getting people more physically active as a priority, it's not an easy fix. You can't just say, okay, we'll really concentrate on active transportation and that will solve the problem. You probably have to do a whole bunch of different things, and it may be a bit hit and miss. So evaluation of what you do is likely to be important because what works in one place may not translate well to another. So, okay. Okay, so we'll look and see how this plays out in 4 countries. And again, these countries are picked both because they have had some success in promoting physical activity, and they've had data systems in place that allows us to actually measure it. And so there are clearly other countries which could be up here, but these are the ones we looked at in that paper. So, all right, so we'll start with Canada. And this is very brief. You can go find the paper and read a bit more about this. And there's a fair amount of literature on physical activity promotion in Canada. The interesting thing here is there were policies put in place to support people being more physically active back in 1961. So the Canadians have been thinking about this and taking high-level policy action for a long time. That was followed with this campaign. Do we have any Canadians here? So are you familiar with participation?
Not at all.
Not at all.
No, first time I'm hearing about it.
So this is an example of it fading from widespread knowledge. It was, for a long time, participation had something like an 85%, there you go, 70-85% message recall, which is phenomenally high for any kind of public service message. And that's because it went on and on for decades. So much so that anything related to physical activity, Canadians believed to be part of participation, whether it was or not. And as in many public health measures, whether it's for physical activity or something else, the money went up and down. And not surprisingly, the effectiveness of the program tended to go up and down roughly in proportion to whether they had funding or not. The second thing the Canadians were ahead of the curve on was, you can see in 1986, they recognized that this shouldn't just be about people doing sports, jogging, swimming, cycling for exercise, that in fact, lifestyle activity was important and should be promoted as part of public health efforts. And they were one of the first countries. So for example, in the US, we didn't change our recommendation till 1995, so we were about a decade behind. And the Canadians were good with data. They had monitoring systems in place and did repeat surveys using the same methodology over time, which actually allows us to come to the conclusion that you do at the bottom of the slide, that prevalence rates of physical activity in Canada went up from 1980 to 2000. The funding went down in the program, So we have an example that declined, so people don't know about it anymore. And the activity levels have actually plateaued in Canada. They haven't continued to go up. Now, this may be because investment in promoting physical activity has gone down. It may also be that there's some kind of upper bound on what proportion of the population you can get active, and that in some countries, like the Scandinavian countries and Canada, things may have been pushed up to about as high as you can expect. Much as it probably would be very difficult to get everybody to quit smoking, it's likely to be very difficult to get everybody to be active enough to meet the recommendations. So. Okay. All right. So anybody know who Paavo Nurmi is? No. Okay. So as you saw on a previous slide, I was a runner and a distance runner. And Paavo Nurmi was a Finn who won bucketfuls of gold medals in the 1920s. He was the best distance runner in the world, and he's still a sort of a cultural hero in Finland, and which is relevant. And so that's so. I don't know if this is true in all fields, but at least in public health, it's like, God, man, the Finns. And nobody can be so organized and on top of stuff as the Finns. And this is really true in public health. And so they were keeping track of everything. And as a result, they have papers written about what they did. They have data collected. And once again, like the Canadians, they were able to demonstrate that they invested in they set policies, they invested in physical activity promotion, they measured what was going on, and they got people to be more active. The special characteristic in Finland and other Scandinavian countries is they were particularly good at gender equity. They got everybody active, and those countries used to, long back, had lower levels of physical activity among women. They, in recent decades, have roughly equal levels of activity among men and women, and which is quite different from most parts of the world. So this is the Cliff's Notes version of what happened in Finland, and you can see again a policy umbrella. They passed policies 50 years ago that were supportive for physical activity, and really importantly, there's a second point there, is that they had national level policies which provided discretionary funding to municipalities to invest that money in things that municipality felt would be beneficial for promoting physical activity. And one of the things they did is invested in infrastructure. And Finland is not a huge country. It's about 5 million people, and 30,000 sites for physical activity seems like a whole lot for a country of 5 million, and particularly when you start looking at big cities that are that size or larger. So.
What does a site for physical activity mean? Is that like a park or?
It could be a track, a
Okay.
park, a gym, a rec center.
And they're always publicly accessible in these?
In
or some of
Finland,
these-
most of these are publicly accessible. There's probably some proportion that are private gyms and clubs and so forth, but and again, this is an underlying issue in physical activity promotion, is whether things are sort of gated, so they're access only to people with money, or whether they're public and they're free. It's clearly a big issue in many parts of the world. And so again, they looked at the data they collected on health behaviors. This was actually in East Karelia, which is the middle of Finland, on the eastern edge of Finland, abutting Russia. And it's an area where they initially focused on cardiovascular disease prevention. And that's basically why this whole effort started, was to reduce the extraordinarily high rates of cardiovascular disease and deaths from cardiovascular disease. So that part of Finland actually all of Finland had. And the physical activity was not the top priority, but it was part of the whole package to reduce cardiovascular disease. So, and then that last point goes back to the Pavo-Nurmi stature. Some of this stuff works a whole lot better if physical activity is valued in the culture. And in all of the countries for which I'm providing examples, there's a high value for physical activity. And so we probably have kind of an intermediate to sort of high value for physical activity in the US. But and one way you can think about this is you think about a country and whether the politicians like to pretend to be vigorous and active, or whether that actually implies that they're poor if they're on a bicycle on a street. And countries in which there's a high cultural value on physical activity, it's not surprisingly easier to get people, push them towards being more active. Okay, so we had two smallish wealthy countries, and you might reasonably say, well, gee, just because you can do something in Finland or Denmark or a little bit bigger, Canada or Australia, do you really think that's going to work in the vast majority of the world where the countries are more diverse, poorer, many more urban problems and so forth? And so we now go to a highly diverse, large country, Brazil, and you know, this is the reality of Brazil. That's Sao Paulo on the right, you know, mega city, and then that's actually in the state of Sergipe on the left. You have people living in circumstances that probably aren't terribly different than they were hundreds of years ago. So a really complicated place to promote physical activity because it's both so different geographically and physically, but also economically. Brazil is one of the countries with the highest economic inequity. But it turns out they've been pretty good at promoting physical activity. And again, we start with policy. The Brazilian constitution was redone, I think, in the early 90s, and it explicitly says that health is a constitutional right. And there's a national health promotion plan, and there's this emphasis on whether it's perfectly carried out or not. There's an emphasis on making healthcare available to everybody with a community-based primary healthcare units, and putting into literally into writing that this is important. So that's a start. And you know, it's particularly notable from our perspective in the US, where it's a fight to get something like the idea that health is a constitutional right it's certainly not written into our constitution in an equivalent way. So I mentioned these physical activity classes earlier. So they're very common in Brazil. The initial work on this was in Recife in the northeast of Brazil. And it kind of picks up on the culture so it's an outdoor culture, it's a tropical climate, it's on the ocean. The beach has high value, whether you're a rich or a poor person. And so the idea that you could put physical activity classes by the beach and then in other parts of the city is valued by people. And the idea of the city was that they would do these for free. They were particularly targeting lower income neighborhoods. They generally had to revitalize the parks or plazas in the poor neighborhoods because they were run down, they were places infested with drug dealers, prostitutes, all the wrong end of society. And they made them safe. They brought in instructors from the city and put on classes. And it turns out that this works. It was very popular, and the program was expanded to all of Brazil. It's had some political ups and downs over time, though. So this is just a quick summary of some of the aspects of this program called Academia de Cidade, and then it was, when it expanded to the whole country, it was Academia de Saúde. The academia in Brazilian Portuguese basically means gym. It's not academic as in our standpoint. You can see they're government funded, they're free. We did some, part of this big project I mentioned it with Brazilian universities and the government. We did evaluation of these, and they're effective both at getting the people who attend the classes to be more active. That's kind of a duh. If you go to a physical activity class, you might just be more active, but it has a ripple effect. More people in the surrounding communities become active, probably because of both the role modeling and the environmental change. You have a node in the neighborhood that's a safe place to go walk around as well as go partake in a physical activity class. All right. Jump to a neighboring country, to Colombia. Colombia is another country that's done, despite rather challenging circumstances over recent decades, going back quite a ways, has actually done quite well promoting physical activity. And the story is somewhat similar. And again, our group at CDC was involved with a lot of collaborations, particularly with Los Andes University in Bogota, on evaluating some of the efforts there. So there's a pretty good literature on what's happened in Colombia. And so there's clearly a bias towards examples where there's actually have been evaluation studies. So there may well be, as I mentioned, a handful of other countries that have done decently in physical activity promotion, but if stuff doesn't appear in either the published or the gray literature, it's kind of hard to know what's going on. Clearly we're seeing a pattern here. So the Colombian National Constitution established, or at least updated in 1991, went a step beyond the Brazilian Constitution in that it specifically identified sports and recreation as a right for all. So this was really important. It was coupled with something else that's really important, which is an allocation of sin taxes to local governments for that sports and recreation. So it's both identified as a political priority and a funding stream was created. We took tobacco and alcohol taxes which could be allocated for local sports and recreation. And probably partly as a result of this, a lot of the innovation in Colombia was at the municipal level. And it was a strong networks of municipalities doing physical activity promotion things. And again, they were very focused on those community classes that I mentioned previously, but also open streets programs. There's sort of a more or less a Colombian innovation back in the 70s that now is quite widespread. And again, there are probably people in this room who study this. They also have been pretty good at providing relatively continuous government support, administrative support, training, networks, first through Coldeportes was sort of like the Ministry of Health and Olympic Committee supporter, and then it became the Ministry of Health. And they've spun off national programs and networks fairly regularly. And one thing they did, which was ahead of the curve, but consistent with what we saw in the WHO recommendations, was they put together a multi-sectoral commission for physical activity, actually in obesity prevention, with the idea that you need to engage agriculture, you need to engage security, local government, municipal planning, as well as medicine and health, schools, recreation, sports. So I mentioned this is COLAF was the Colombian Physical Activity Network, lots of municipalities, and it's evolved a bit this particular initiative has changed names a few times, but it's an example of that sort of underlying modest but important government support to encourage the municipalities to share best practices, to have trained staff and so forth. So, if your goal is to get more people to become physically active, you probably need a workforce which helps to push people in that direction and provide the technical support. And Colombia is one of the handful of countries that's done this decently. So I mentioned the obesity law. You can see kind of the summary there, and you can see that it involves multi-sectoral, higher level policy thinking across things. Okay. How many people here are familiar with the ciclovia in Bogota? Yeah, so most of the group. So so I'll say a little bit about it. You feel free to chime in. My experience in the ciclovia is now a decade or more old, but I've been in it quite a few times, and probably the main researcher who's done the most on this is not very clear here. It's Ogalicia Sarmiento, who did her PhD at University of North Carolina, and has been a professor at Los Andes University in Bogota now for quite a while. So in the Colombian vernacular, ciclovia is an open streets program. Most places in Latin America, ciclovia just is, it's a literal translation, it means bicycle path. But in this context, it's a program in which regular city streets are closed to automobile and bus traffic and are made available for people to either to walk, to run, to use some human powered form of wheeled transport, skateboards, scooters, bicycles, etc. And it makes a big difference. One of the reasons it's probably important in cities like Bogota is, as you might imagine, on a regular day, this street is the Septima, which is the main avenue, North-South Avenue in Bogota. And you can see it's crammed with buses, cars, and taxis, and pollution levels on a regular day are extremely high, surprisingly. And then on a ciclovia Sunday, there's much less automotive traffic. They keep some lanes open for transport, and the pollution levels go down. So you get back to one of our other issues, the environment in which you're active matters, and this is a better environment. But probably the real benefit of the ciclovia in a city like Bogota is that it opens the city. It uses existing city space, which you might think is only for cars and people with cars. And in Bogota, only about 20% of families have cars. So you have created, but everybody pays taxes. And so you have basically repurposed existing public space to make it more accessible to a broader range of people, and provided a whole lot of infrastructure to support it. So the typical ciclovia has about 2,500, ciclovia day has about 2,500 volunteers. A lot of them are actually high school students who are fulfilling their public service requirement by working there. So it's really a carefully thought out program. And of course, in contrast to the efforts to do this in the US, it's basically supported, as in paid for, by the city. So police protection is provided by the city, just like they would provide police protection and traffic control on those same streets on any other day when the cars were using them. Same thing now that people and bicycles are using them. So and you can see that these numbers are from a few years ago. They're probably roughly still correct. A lot of people use it. The rough estimate is about 1 million people or something around 10% of Bogota's population are out on those streets every ciclovia day. As I mentioned Sundays, it's typically Sundays from 7 in the morning to 2 in the afternoon. Why are there 72 events? Colombians really like their holidays. So it's holidays and Sundays. And the participation is across society. 92%, the 4 bottom SES categories of the 6 that demographers use in Colombia. That isn't really disproportional. That's roughly proportional to how the population breaks out. The highest economic classes account for less than 10% of the population. The other 90% are actually using the ciclovias. When the program started in the 70s, as you might imagine, it was the lycra cycling crowd. So cycling advocates from wealthy families generally who pushed the idea to close a small section of streets, but the program grew, and it turned out that one of its best attributes was this idea of ownership of the city, so that even if you were from a poor neighborhood, especially when the ciclovia was a couple of very visionary mayors, expanded it from just the wealthy parts of the city to connect over the whole length. Bogota runs a long ways north-south. The north is rich, the south is poor. Initially, it was just in the north, and then it was more or less connected to all parts of the city. And so it gives people a sense that the city belongs to them, not just to the wealthy people and the ones who have cars. And I think that's been one of the most compelling parts about the spread of these programs, is that they have an equity component. Oops. Yeah. This slide's in Spanish, but you can the components of it, you can still make sense of it. The idea is that the ciclovia really is a multi-sectoral event. So we did a network analysis on this. The bigger the circle is, the more connections, and then you can it's the stronger the connection. You can see that recreation and sport manages the ciclovia, so they're central there. But the transport and urban planning, the blue, are really critical. I mean, they own the streets, so you can't do an open streets program without them. And that over here, security is really important. And this is a huge issue in physical activity promotion in most parts of the world, is that you need safe public spaces if you want people to become physically active in them. And then there are multiple other sectors. Health is was late to the game and never really that important of a player in this. And this is kind of an underlying issue in physical activity promotion, so I'll get to it. People like me in health are the ones who typically generate the recommendations for how active people should be and the strategies. And then we tell people like you, who are in a different sector, and you say, you should probably be spending your money to promote the stuff that we need promoted. And it might be a relatively easy sell for an active transport crowd, but it's a pretty difficult sell in general. So.
Yeah, so I'm curious, I know City of Los Angeles have adopted ciclovia as well in their city. They don't have events as frequently as Colombia, but I'm curious through your research, have you looked at other cities who have also adopted this model and the expensive as on their cities?
Yes, and I'll get to a little bit of that. So there's been Pan American Health Organization made a pretty big effort to promote this model, and for a while supported a network to help push it out. And so there are 300 plus cities in Latin America that have some degree of a ciclovia in streets. And some of them are very big. Like, Guadalajara in Mexico is a large one. And then there's been a lot of effort to adapt it to the US, yes, which has been kind of hit and miss.
Yeah.
And and the reason mostly is that it's some combination of academics and foundations that typically, and community groups that do it. And they have almost never been able to get the municipal support, like you see on this slide, that makes this sustainable. So that events tend to be fewer in the US, and they're kind of erratic. So we had a run when I was at CDC in Atlanta that we had a city council person who became a big advocate for this. And he was actually able for a few years to get half a dozen events a year with police protection and several miles of streets. But again, you look at it and you say, well, Bogota's got 100 plus kilometers of streets and 1 million people on it. And you know, kind of the best we can do in the US is much short of that.
Right.
Yeah, so I think it's, and some of this is the bigger issue of investing in common good, you know, because that's, you have to be able to convince the policymakers that this is a public good in the same way that having traffic lights and crosswalks and, you know, the other things related to street infrastructure is. But
Dr. Pratt, we've got about 10 minutes left.
okay, yeah, we're getting towards the end here. Yeah, so you asked about other cities. This is one of the analyses that came out of that. I'll just cover it briefly, but so these are 4 of the examples. So this included Sunday Streets, which had a brief run in San Francisco, plus programs that have been sustained in Guadalajara and in Medellin. And so this was quite a few years ago. There are quite many more now, but lots of cities in Latin America. There's enough research on these, although the research is messy. So it doesn't fit into the typical health research because it's uncontrolled. But these kind of programs have the potential to get a whole lot of people active on a regular basis if you can open the streets up on a regular basis. And the health economic analyses not many have been done, but they're pretty consistent. They show that there's an economic benefit to these. The example in Bogota was interesting because there was initially a lot of pushback from businesses along the routes and the proposed extended routes because they thought without parking and access for their customers, they would lose money. Well, it turns out, and this is, people who are familiar with trail studies know this tends to be true there. It turns out if you run a whole lot of people past your business, it's good for your business. And if you put 1 million people on the streets, it turns out it creates a whole new market for small vendors set up along the way to sell food and fix bikes and do all sorts of things. So. Okay, same sort of summary in Colombia as in the other cities. Again, policy umbrella, money getting to the local level to promote physical activity, and a little bit of evidence that activity levels actually increase. It would be nice to have, and seen as the National Health Survey in Colombia, the next one got derailed by COVID, and it still is. There's still not data from that, so we may be able to update this, but okay. I've kind of walked through this along the way, but you can see this list. There are commonalities between these countries which have done pretty well with physical activity. They do have the support of public policy. You can't change population level behavior without investing in it. You need both policies, you need commitment of money, you need places for stuff to happen, so the public space and facilities are important. Equity is important in this, and it's interesting that, you know, Finland and Canada are countries that we would look up to as being equitable. Less income inequity, an emphasis on rights of everybody. Brazil and Colombia, less so, but they care about it. And so programs like some of the public transit programs in places like Bogota and Medellin, and library programs and this physical activity programs have been attempts to provide services to the very large poorer population. So there's a value in addressing inequity that translates to programs like the Open Streets program. Obviously, it's not solving all of societal problems, but it's a driver for it. And then I mentioned the cultural relevance of physical activity before, and the networking among professionals that do this kind of stuff is quite important, because most people who do it are on the margins in their field. And by connecting with other people, they realize they're not the only ones doing this. They can obviously learn from other cities and examples. Okay, already showed that slide. So I'm gonna go to the next one. I kind of mentioned this. So this is kind of the pathway for promoting physical activity. We generate the science. We come up with policies, and this is usually, as I mentioned, this is usually the public health people, the government in some form. And then we have as in all fields, there's a pathway to get it out to the people. Typically in the US and in many countries, something like a state health department is given the mandate to implement this national policy. And then that goes down to the local level. And that's where physical activity happens. It happens on the streets and parks and schools and playgrounds and so forth. And the problem is, by the time you get to the local level in health, there's actually nobody there who does this stuff. So there's lots of talk, but then when you get to the local level, rarely are there people trained to do anything with it. And the issue, of course, is all these other sectors, which you can see here: education, transportation, environment, planning, sport, are the ones who really need to be able to do the work, but they probably should have been part of this whole process earlier on to buy into it, and it may be quite difficult to get them to allocate their resources there. And so the places where you see good physical activity implementation, no surprise, are ones where there's good multi-sectoral, intersectoral collaboration. There's some really nice work that's been done in the south of France on this that gets at this issue. Okay. So I mentioned the non-scalable research models, and again, we talked about this. The fourth bullet point there, I think, is the one that's relevant, which is that there's a lot of large-scale stuff that goes on, and much of it is in the active transport realm that health researchers don't tend to evaluate. And perhaps transportation researchers have evaluated it, and health people like myself are just not so much aware of it. And this comes from a paper that we did in 2016 where we did a systematic review. But the interesting thing is that Rodrigo Reis, who's a Brazilian who's now at WashU, is redoing this analysis. And so what he's done, these are the broad categories of promoting physical activity. And the bars represent the amount of review studies that were available in 2016, and then the ones that are available now. And look at this, active transport. No studies in 2016, all of 2 now. and active urban design, no studies, period. So it's like, from a public health standpoint, those are two of the most important things, but health researchers don't study them. And not surprisingly, we're not very good in these areas from a health standpoint. So it's a real disconnect between how important, not just how important inactivity is, how important these categories of intervention are. And that the research system in health does not incentivize studying these. So not surprisingly, health researchers who are like most researchers, they're largely on soft money. They need to respond to what NIH funds. And if you don't fund stuff, the research doesn't get done and we don't have good information to make policy. Okay.
We're getting about to 3, so some folks might need to start heading out, but I think I don't think there's anything in this room afterwards, so we can.
Okay, I'll wrap this up pretty quickly. So it's a couple newer studies that kind of bear on this. This one was looking, this is a post-COVID study looking at how it impacts physical activity promotion. And you can see, not surprisingly, most of the impacts were negative. Closing of parks, closing of schools, keeping people away from each other. But a handful in a few countries were actually opening up the streets. Paris is a good example of this, and getting people to use active transport instead of subways, buses, other forms where people are packed together close and at more risk of disease transmission. So if we look more closely at some of these studies that involved studies of cities involving active transport, what you can see is that you can read this on the right. That's basically the one paragraph summary of the paper. But in fact, a whole lot of cities took actions to promote active transport during the COVID pandemic. Some of them have maintained it, but a lot have backslid to the way things previously were. But it's an interesting example of this policy window opening up for change and being able to make change rapidly. So I think it's even if not all of these things have been maintained, I think it's an important sign that active transport probably moved higher on the policy agenda for general policymakers than it was previously, because it could help solve a huge urgent problem, the COVID pandemic. And so I think this is a bit of good news. Okay, I mentioned this before. I have a couple slides. I'll just show this one, but the next one is actually very similar. So these are density maps, so by country. So the size of the country on this map, on the top one reflects the population. So you can see India and China are big. Australia is just a little sliver there. And then on the bottom is where the physical activity research comes from. And the peach colored ones are high income countries, and green are middle income, green or upper middle income. And you can see that the research takes place in the wealthy countries. People live in 90% of the population of the world are in low and middle income countries. So we're really missing a lot of contextual research that would presumably help tailor better interventions for those places. So again, back to your comment early on. And there are some exceptions to that, and they're particularly noticeable in more recent analysis. You can see that Brazil is actually pretty big on this map, and so is Colombia, and South Africa has appeared. So there are a handful of low and middle income, and China actually is a little bigger on this map. There are places where there's research being done around the world that's more contextually developed. So. Okay, you can see I've touched on most of these things along the way. There are a lot of challenges in doing this kind of work. And the bottom one is probably the most important and relevant here, is that collaborating across sectors is always difficult. And in these issues that are so dependent on cross-sectoral collaboration, it's essential, but it's not easy. And we're gonna go to the end. So you get a La Jolla picture there as so beaches instead of flat dirt, although I'm very happy to be here in the place of flat dirt. Happy to answer any questions, and I can stick around for a while.
Wonderful, thank you so much.
So
Yeah, if you're able to stick around, people have questions that you want to ask individually, feel free to do so. Otherwise, have a great rest of your Friday and weekend.